Hey folks, we're live at Troy, Alabama. Thanks for hosting us, guys. Troy Fire and Rescue, really appreciate the support. Y'all been good to us for years now. We got the fellows, Dr. Kirby and Dr. Sullivan, talking today. Just a couple of updates. Remember, the state conference is next month at Orange Beach. Come out and see us. We'll be streaming live from there, plus a lot of good both local, regional, and national speakers out that way. I think there's a cadaver lab and some critical care stuff. They're also going to be talking about the new 911 dispatch protocols coming out. And I think it's either Tuesday or Wednesday, there's a medical director's curriculum. So if your agency has a medical director that has questions or concerns about things that are done in Alabama, send them there. So a lot of good things coming up. We'll also have a cadaver lab back in Birmingham mid-December, or probably first week of December, but that'll be posted on Eventbrite pretty soon as well, and that's all free. So thanks for hosting us, and we'll get you started.
Sweet. What's up, guys? I'm Paul Kirby. I'm one of the EMS fellows this year. A little better looking than Dr. Sullivan over here. But we'll get started today. Mine's probably going to be about 15 minutes. Non-cardiac chest pain, which kind of limits you, and we'll get through it a little bit. But essentially what I'm going to talk to you guys about is some of the life threats that you can have that aren't cardiac. The weird thing is that there's probably not much y'all can do out in the field with some of these things, except if you take a good history and you recognize it early, it's going to make a world of difference for the patient. So just as a disclosure, Dr. Ferguson and his associates, us, have no financial relationships to disclose, except for the Fire College, UAB Emergency Medicine, and the residency program. We're at EMS Challenge. Here's all the dates going forward, and we get to objectives. First, we'll go through anatomy review. Then we'll discuss different cases and presentations of non-cardiac chest pain, discuss treatment options, and we'll review some of the life threats. Pretty simple stuff. If you look at your thoracic wall, so your chest cavity, okay, on the outside, the wall itself, you're going to have ribs. You're going to have 12 ribs. The first 7 are going to be your real ribs, true ribs. So those articulate with the sternum itself through that cartilage. And then you're going to have false ribs, 8 through 10, which are below that a little bit. And they're false ribs because they articulate with the sternum, but it's not quite like the first 7. And then right below that, ribs 11 through 12, you have your floating ribs. Okay, so you have the ribs go through the front and articulate with the sternum through the cartilage, and they articulate with 2 vertebrae in the back each. So this is kind of your cavity itself, and then the cavity is brought together by all these muscles, and there's all kinds of muscles. You have, I think, 4 or 5 different layers of muscle in between the ribs. The main ones are going to be your external intercostal, your internal intercostal, and your innermost intercostal, and they're all sitting right in between the ribs. I wanted to bring this up because, one, these muscles aid in respiration, so they contract, your chest wall comes out, decreases the pressure in your chest, so air flows in. Okay, your diaphragm pulls down, increases, I guess, the volume, so the pressure goes down, air goes in. So that's how you breathe. And if you look at these muscles, so you have your external on the far left, and then you have your internal and your innermost, and then you have the neurovascular bundle sitting right below the rib. So I just wanted to point this out because this is why when we tell you to decompress or you see someone put in a chest tube, we always try to go above the rib. If you go below the rib, you're at risk of hitting this artery, which makes for a really bad day. And if you've ever been diagnosed or had someone diagnosed with costochondritis, I wanted to throw this in here, not necessarily a case itself, but essentially it's where the ribs and the sternum come together, that cartilage that brings them together, it becomes inflamed. A lot of times it could be a virus, it could be overuse, coughing, it could be bruised just from trauma. But as the treatment for this is going to be NSAID, stretching, ice, and just time. I think they usually resolve it in about 7 to 14 days. Not a big deal. But you will have patients that are complaining of chest pain, and you press on their chest right here along their sternum, and they're like, ow, that hurts. That kind of makes me think that this isn't necessarily cardiac. This isn't anything in the lung space. This is going to be musculoskeletal pain, so costochondritis. If we go a little deeper and we go into the thoracic cavity itself, this is what's holding your lungs, your heart, all your great vessels, your diaphragm, all the important things. Okay, so you're going to have 2 pleural cavities, you're going to have a pericardial cavity, then you're going to have all your vessels. You can get into the weeds about the mediastinum itself, and you can split it up into the superior mediastinum, the anterior mediastinum, the middle, and the posterior. I'm not going to talk about it too much, but essentially your anterior is going to have all your like ligaments and everything. Your middle's your heart. The posterior is going to have some of the vessels running down, and then your superior is going to have like the aortic arch and esophagus and stuff. If you look at the pleural cavities themselves, you're going to have your lung, and then you're going to have the lung that goes around, or the pleural space that goes around the thorax. So you're going to have your pleural space or pleural cavity, and you're going to have your parietal pleura and your visceral pleura. Visceral pleura is going to be around the lung, and the parietal is kind of going to be around the ribs on the outside. Well, when this gets irritated, you have what's called pleurisy. I don't know, again, if anyone's ever been diagnosed with something like this or said like they have pleurisy. It's kind of just a broad term. It's just inflammation between this space. And so this could either be due from a virus, which is a majority of time, but this could also be caused by pleural effusion, hemothorax, PE, different things that are just irritating this area of the lung. And so I say that this is a diagnosis of exclusion because someone comes in complaining of like pain when they take a deep breath over here on the side. They have other risk factors. I'm still working them up. I'm doing all the cardiac stuff. I'm looking for PE. I'm looking for all the life threats. And then when all that's is done, I diagnose them with pleurisy. I tell them, here's some NSAIDs, rest, follow up with your PCP, okay? But I just wanted to point this out because a lot of people are diagnosed with pleurisy. And I want to point out that, yes, most of the time it is viral. It's irritation between this spot, but it can be bad. So you have to make sure it's nothing else. All right, so let's get through some of these cases, and hopefully some of these cases are pretty interesting. But case one is a 42-year-old female that presented with 3 hours of substernal chest pain, shortness of breath. Pain started suddenly while walking upstairs. She describes it as sharp, worse with inspiration, not radiating, no fevers, cough, trauma, no sick contacts. She's tachycardic. Her blood pressure is 122/76. She's breathing 24 times a minute. She's 91% on room air, afebrile. She appears anxious, mildly diaphoretic. Lungs are clear. She has mild right calf tenderness, no JVD, no murmurs. All right, so y'all get called out to the field for something like this. What are you going to do? You already got vitals. You want any other history? What do you want? What about history of travel? Say she just got back from a flight from Indonesia or something. Maybe she has a history of blood clots. Anyway, you're probably she's complaining of chest pain, right? So you're probably going to get an EKG on her, and you get an EKG like this. First, you got to look at it and say, is this good or bad? I would argue that this probably doesn't look normal in a 40-something-year-old woman, right? And so you start looking at it, and you don't necessarily see ST segment elevations or depressions. And secret's out, this is a non-cardiac chest pain, right? But there's definitely something stressing out the heart on this. If you look closely, you have what's called an S1Q3 T3 pattern on this. So in the first lead one, you have QRS, so a deep wave going down, the S wave. And then in lead 3, you have a Q wave, so QRS, and then your T wave inverted. That is indicative of acute right heart strain. Okay, and so in this case, this patient has a pulmonary embolism. Okay, so acute chest pain, right calf pain, probably recent travel, oral contraceptives. She has a pulmonary embolism. If you look at this image, you see the pulmonary, the pulmonary artery trunk come down, and you see these blood clots on both sides. This is a little better picture of a saddle embolus. This patient probably didn't have something like this, but this is her PE right here. If we talk about PEs, it's about 60 to 100,000 deaths per year in the United States secondary to PEs, and over 300,000 deaths in the Europe area. So it's one of the leading causes of mortality and morbidity. The good news is that all this has been improved over the last 20 years. We're catching them a lot quicker. So over the last 20 years, we have come up with this thing called CT scan, CT angio. And so a lot of times we're catching them when they're smaller, not getting bigger. We're recognizing some of the risk factors. We're jumping on them a little earlier. We are catching like the small PEs, but the small PEs aren't really what's causing all the problems. It's the big PEs. And so when a patient comes in like this, I ask her about all of her risk factors. And you have strong risk factors and you have mild risk factors. So some of the strong risk factors would be like a recent fracture. They've been immobilized. They've had a major surgery, major trauma. Moderate would be like they had a knee scope. Maybe they're on oral replacement therapy, hormone replacement therapy. They have CHF. They have cancer. And then your weak risk factors of like they've had the flu for 3 days, immobility, prolonged car travel, increasing age. So all these things start, when I have a patient show up, start making this more likely, less likely in my head, and I can use other decision criteria such as the PERC or Wells. I just wanted to mention this. You guys will never use this, but this is what I'm going through when you bring them to the hospital. So this patient came in, she's tachycardic, she's 40-something years old. According to the PERC criteria, I can't PERC her out. So that means I have to go forward. I have to go forward with something else. If this patient was 40 years old, not tachycardic, was satting greater than 95%, no blood in her cough or sputum, no prior PE or DVT, no hormonal use, then I can PERC her out. I don't have to get a CT scan. I don't have to do anything. Okay, this is saying that the risk of her having a large PE is so low that I don't have to scan her or work it up anymore. But in this case, she's 40-something years old and she's tachycardic. She was like 116. So I can't PERC her out, so I move forward and I go to the Wells criteria. Again, it's another decision tool. I input a couple things and she'll either be mild, moderate, or high, okay? Heart rate's greater than 100. She had signs and symptoms of a DVT when you squeezed her calf, so that's +3. You have the heart rate 1.5. Anything greater than 2 is going to be moderate. Anything greater than, I believe, 6 is going to be high. So if the patient is high on the Wells score, I'm going to go ahead and get the CT angio over chest. If it's moderate, I'm either going to get the CT angio or send a D-dimer. If it's low, I'll probably send a D-dimer. And then if the D-dimer is high, I have to get the scan. A lot of this, again, is to help us decide who are we going to scan, who are we not going to scan. There's so many factors that go into it. Is it a busy department? Am I concerned about it? Do I just need to, am I scanning something else? Do I just need to get the scan? Just wanted to kind of point this out for y'all. One of the other things you can do is you can look at the heart with an ultrasound. Again, I talked about the EKG, the S1Q3T3 pattern, and how that's indicative of acute right heart strain. If you take an ultrasound and you look at her heart in the, I guess, parasternal short axis, you'll see what's the mitral, right below the mitral valve in the left ventricle right here, that big circle. See how it's circle right there? And then you have your right ventricle above it, which is a little smaller, but that, left ventricle is the circle, right ventricle is right above it. Right ventricle is not quite as thick, so that's how I know the left ventricle is below, but the left ventricle is a circle. That means it's contracting well, and there's not a lot of pressure below it. If I take an ultrasound on the heart, which I think ultrasound is going to end up moving into y'all's field at some point in time. We got one down over here now that we're going to start using. If you throw it on the heart, you'll see pressure from the right ventricle on the left ventricle. So the blood flow from the heart to the lungs is limited, so it's backing up into the heart, causing pressure on the other system. So you can see what's called a D sign, where that left ventricle looks like a D right there. So if I see this on someone, if I'm ultrasounding them, I'm going to scan their chest. I'm going to have a high suspicion for PE. Treatment for you guys in the pre-hospital setting is going to be supportive. You want to be careful with fluid boluses because you don't want to increase the preload because that's going to worsen the right heart failure. I didn't get into that too much. If they're hypotensive and they're having chest pain, you're probably going to give them fluids because you're going to think it's going to be a heart attack, right? Especially with an abnormal EKG like that. I don't think anyone's going to fault you for that. It's just if you have a high level suspicion of PE, so they have a swollen calf, they have dilated or history of PEs or DVTs, they're supposed to be on anticoagulation and not, and maybe you think they have a large PE, maybe be careful. Don't give them the full liter, maybe just 250 boluses at a time. In the hospital, I'm going to evaluate them and I'm going to essentially decide, do they need an admission or can I safely discharge them on anticoagulation? If we look into it, if I admit them, they're either going to probably get a thrombectomy or they're going to be started on heparin, okay? If they're coding, I'm giving them T and K and I'm trying to just break open whatever clot it is to reperfuse everything else. And if I discharge them, probably on Eliquis with follow-up with PCP in a couple months. But if we go back to this large PE, this saddle PE, They'll probably have evidence of right heart strain, like the ultrasound. Their troponin will be elevated, BNP will be elevated. They'll probably be a good candidate for a thrombectomy. And what this is, they go in with a camera and they break up all the clots and they suck them right out. And they put them on a little chart like this. So this person wasn't the same person, but had a pretty good little clot burden right there. I promise you that if a patient has a blood clot like this, they will not look very good, right? They're going to be tachycardic, hypotensive, hypoxic. They're not going to be doing well. You're going to be driving fast. Found this article, Disposition of Emergency Department Patients with Acute Pulmonary Embolism After Ambulance Arrival. Essentially what this said is that if someone complains of chest pain and they're found to have a PE, if they're brought in by you guys, that probably means they're going to be admitted. They have a higher mortality and morbidity. If they come in off the street, private vehicle, not quite as bad. So this was kind of refreshing to me because we do see a lot of, non-significant calls. I mean, y'all know that, right? You see a lot of non-significant calls, but if someone's diagnosed with a PE from that standpoint and they've called y'all, it's probably going to be significant. All right, summary case 1. So their chest pain is going to be the pleurisy. It's going to be the lining of the pleura. You could have pulmonary infarct and ischemia, so you could have some pulmonary component of that as well, and you'll probably have some cardiac. Again, I know this is non-cardiac. Risk factors, recent surgeries, prolonged immobilization, hormone replacement, and history of clotting disorders. Treatment is going to be supportive, and again, be careful with fluid boluses. I don't think being careful with fluid boluses is ever going to be the wrong answer. I think you can always start with 250 and keep evaluating and just pumping in 250 if you have to, but it's easier to adjust after 250 than it is adjust after a liter, if that makes sense. All right, case 2.
Hey, I'm going to throw one thing in.
Any questions?
Okay, sir. Yeah. So, we talk about some of these things about going in with a catheter and doing interventional stuff. I know some locations don't have access to that like we do in Birmingham with the academic shop. My point to that is that every hospital now has TPA or TNK, the same drug we use for strokes or for heart attacks. So it's the same thing. It's a lung attack, right? So your local hospital, if they recognize that PE, if you recognize it, you pass that on to them, they recognize it, they can lyse that person, which may buy you time to salvage you to get to the academic shop. And actually, sometimes you just lyse them and it fixes the problem altogether. You don't have to go anywhere. So this is a salvageable patient at a local community hospital if you recognize it. So if you got a choice of going to hospital A, which is 8 minutes, but you think is a 4-bed ER with just an ER doctor, maybe I shouldn't go there, versus a 40-minute transport time to hospital B that's got multiple doctors, you're more comfortable with that. Hospital A may be able to do it because if they have TPA or TNK, they can fix that problem if they recognize it. So just throwing that out there. Sorry. I had Mountain Dew this morning. I'll be quiet.
No, I mean, that's a good point. A lot of times they're going to be started on like a bolus heparin drip and then be transferred. I think they'll save the TNK until they look pretty bad.
Yeah.
And if they look that bad, you are going to stop at the nearest hospital no matter what versus going 40 minutes, like you're saying. Any other questions about that at all? Case 2. So we have a 58-year-old male presented to the ED with sudden severe chest pain. He described it as tearing, radiating to his back, watching TV when it started, not exerting himself. History of hypertension, smoker, no prior PE. His heart rate's 98, BP's 180/90. Let's just say you took it in the right arm first. Respiratory rate's 22, O2's 97, temp 98.4. He's anxious, diaphoretic. Diminished left radial pulse, no rails, no murmurs initially. Anybody got an idea? Okay, so you do all the things, right? You check a glucose, you're getting a further history, you get into EKG. So you read your EKG like you've been taught to. You say it's sinus rhythm. There's P waves for every QRS. It's normal access. There's really no ST elevations, ST depressions. The intervals look okay. Looks like a normal EKG, and this is a non-cardiac chest pain, so it's a normal EKG, right? So you take them to the hospital. You get there as fast as you can, and they're doing all the things, and they get a chest X-ray, and it looks like this. Looks weird, right? Like it looks like the lung spaces itself has shrunk. It's not the lung spaces that have shrunk. It's actually the mediastinum that's widened, right? So you have a widened mediastinum in someone that's complaining of severe chest pain radiating to the back. And if you looked at the vital signs, they had abnormal blood pressure, right? They had elevated in the right, lower on the left. diminished pulses on the left. They have what's called an aortic dissection. So their aorta has sheared and has been tearing. So they show up to the emergency department. We are able to get a CT angio of their chest. Again, not looking for PE, but looking for a dissection. And you see the little intimal tear. So I don't know if y'all can see it, but at the bottom down here, this is your true lumen. So this is what all the blood flow is flowing through right here. And all this is false lumen. So there's blood leaking into that false lumen right there. So they're going to have sharp tearing chest pain radiating to the back, different blood pressures in each arm. Okay. There's different type of aortic dissections. I just wanted to mention this. So the one that's probably going to cause your chest pain is going to be your type A, which is from the aortic arch. Your type B goes down and go down as far as it can, but it's after the arch. So your type A is the one that needs to go to surgery immediately. The type B, they can watch sometimes. Unless it's too big, they'll go ahead and stent it. So this patient, you drop them off at the emergency department. Maybe they are found to have a dissection, and you're at a small hospital, and then you start transporting them, and all of a sudden they become tachycardic, hypotensive. They don't look too well. Okay, well, you're in the back of an ambulance, can't do much, but you get an EKG like this. You're like, well, that looks different than the first one. What's going on here? And it's loud in the back, and you start looking through it. Sinus rhythm, narrow QRS, normal axis, no ST elevations or depressions, but it looks weird, right? It looks like some of the QRSs are shorter than the others. So short, big, short, big. This is called electrical alternans. Okay, so in a person that has an aortic dissection, specifically a type A dissection, they can actually dissect into the pericardial sac and cause a pericardial effusion. And so if you have tamponade, you'll have this electrical alternans where it's going back and forth because the heart's trying to beat into a sac of fluid. So it's not able to beat the same each time. It'll beat and then it'll be squeezed. And so the next beat will be a little smaller. Then it'll gain it back and big, small, big, small. So that's why it looks like that. So this patient has a pericardial effusion. So if they have evidence of tamponade, you need to do a pericardiocentesis. They need to go directly to the OR. Very scary situation, neither of which you are doing in the back of an ambulance. But again, if you're able to recognize these things before you get to the hospital and let the doc know, that's going to save the patient. That saves the patient, and that gives the doc an extra advantage. So the treatment for this in the pre-hospital setting, if they are hypotensive, give them blood if you can give them blood. You don't want to, raise their blood pressure super high like in dramas. You want to do permissive hypotensive. You want to treat their pain. This is going to be pain and supportive care. In the hospital setting, we're calling a cardiothoracic surgeon. We're getting invasive blood pressure management. We're controlling their heart rate and their blood pressure. So we're trying to get their heart rate down between 60 and 80, blood pressure 100 and 120. We're going to start with probably an IV beta blocker to bring the heart rate down and their blood pressure down. Then we'll give them something else on top to give them, get their blood pressure down. The reason being, you don't want a shear effect. So if you lower someone's blood pressure due to vascular resistance, so you make their vessels bigger, a lot of times they'll have reflex tachycardia, so their heart rate will beat faster. In a case like this would cause a lot of stress on that aorta, so you don't want to do that. You want to keep the heart rate down first and then work on the blood pressure. So summary of case 2, the pain they're having here is going to be vascular. There is going to be some pleuritic and cardiac chest pain, especially if they're bleeding into the pericardial sac or if they have an effusion. Sharp tearing chest pain radiating to the back or aortic dissection until ruled out. They'll be like, my scapula is hurting. There's pain right between my scapula. I'm scanning them. I'm looking for an aortic dissection each time. Beware of different complications like pericardial effusion or tamponade and hypertension from blood loss. And then if you're concerned about this, one of the best things you can do is take a blood pressure in both arms. If they're having a dissection of some type, they will have different blood pressure. And then if you're asked to do blood pressure management in the field, make sure to use beta blockers first to get that heart rate down. Any questions of case 2?
Hey, Doc, we got a couple questions there. So one is the electrical alternans.
Yes.
How reliable of a sign is that cardiac effusion? And does it go away as that progresses into tamponade?
I'd say it probably gets worse as it goes into tamponade. The only time I've ever seen it was when it was a pericardial effusion. As far as sensitivity and specificity, it's probably pretty sensitive if I had to guess, but not specific.
Okay.
I don't know if that makes sense or if that answers the question.
So if they're having a fusion, it's likely to show up, but it may also show up for other reasons.
Yes. Yes.
Okay.
That's yes.
So if we think our patient has a dissecting aortic aneurysm, definitive care is going to require a thoracic surgeon. Is that right?
Yes.
What's the availability, if you know, Dr. Person might know, the different regions of Alabama where they're likely to have capability to repair a dissecting aneurysm?
Yeah, all management for those patients initially is being medical. So it's going to be recognize it, blood pressure management, and get the diagnostic so you can get that surgeon there. So I wouldn't say if you're an hour and a half away from a thoracic surgeon place that you make that transport initially. Get to the local ER, have them make that diagnosis for you, the range transfer. As we move forward, at least in the Birmingham region, and we have a regional med control, those are things that we'll have access to real time. But trying to do that statewide is challenging. We can do it with our trauma and our STEMI and our stroke, but even then, right now, that's challenging, if that makes sense.
Yeah, I actually asked that question because I have some personal experience with family member that had a aortic dissecting aortic aneurysm, and they had to be moved from the whole region of the country they were in. There just wasn't anybody available to do that surgery, and that was a while back. I'm just wondering if that's changed or if that's still a pretty specialized, hard to find thing.
Yeah, it's still probably pretty hard to find, but you do want these patients to go to the nearest hospital so they can get stabilized and you can find it. It is a pretty rare diagnosis, but it's important to find it.
Good, thank you.
Y'all must be the rookies or something. Y'all got ditched, didn't y'all? All right, case 3. 24-year-old, tall, thin male, sudden left-sided chest pain, shortness of breath. Pain began at rest 30 minutes ago. Says worse when he takes a deep breath. No recent trauma, cough, or recent illness. He's tachycardic. Blood pressure is 128/74. Breathing fast. 94% on room air. Mild distress. He's speaking in short sentences. He can't really get a deep breath. And decreased breath sounds on the left. So this would be like a spontaneous pneumothorax. Again, so this isn't traumatic chest pain. You'll have that next, but this is spontaneous. The only place you can really see this is on the top, I guess, left. You can really see where there's no lung markings. So he's having a small pneumothorax up there. If you weren't sure on chest x-ray when they get there, you can take an ultrasound and put it on their chest. And when I take the ultrasound, I'm looking for, do they have lung sliding or not? And so if they have lung sliding, you'll have a seashore sign. And if they don't, it'll look like a barcode. And I usually have to take it multiple different places just to compare and see. But if you see that x-ray and you see ultrasound like this, then that's a pneumothorax. For spontaneous pneumothorax, a lot of times this can be with or without underlying lung disease. So this could be older patients with COPD, cystic fibrosis, interstitial lung disease, or it could be a tall, thin, Ehlers-Danlos, marfanoid guy. And a lot of times this is a subpleural bleb. So if they have these symptoms, decreased breath sounds, it's probably a spontaneous pneumothorax. The good news is that the treatment's about the same as all the other pneumothoraxes, except if they're young, healthy, the pneumothorax is small, they're hemodynamically stable, you're just going to put them on 100% oxygen via non-rebreather. You're going to watch them for probably 6 hours, repeat a chest x-ray, and a lot of times that might be absorbed or it'll be stable and they can be discharged home. What you don't want to do is you don't want to put a BiPAP, CPAP mask on or intubate them because that's going to make that pneumothorax worse. You just want to give them some oxygen. I tried to look up the data. It doesn't quite make too much sense to me how you give them oxygen and it sucks out the oxygen in the lungs. But it's the same thing if they have oxygen in the brain after like a GSW, like a pneumocephalus. You put them on oxygen and it absorbs some of that oxygen somehow. Now, if they're unstable, you're going to do all the things. You're going to do the needle decompression, and then you're going to do a thoracostomy with a chest tube. And then put them on suction and admit them upstairs and keep an eye on them. Again, needle decompression, you're going above the rib, second, third intercostal space, or lateral fourth, fifth. I think we'll probably talk about that next presentation. So case 3, this chest pain is going to be pleuritic chest pain. Does not have to be traumatic, so you do have to suspect this even though they didn't have a car accident or a GSW. If decreased breath sounds stable, place on oxygen. If decreased breath sounds unstable, decompress the chest. I think argument could be made for putting them on oxygen either way there. Any questions about that one?
I know a lot of the textbooks talk about there seems to be some correlation, at least anecdotally, that patients will report they hear a pop or the onset happens while they're taking a shower. That makes no sense to me, but I have to say that every time I've ever had a patient that ended up having a spontaneous pneumothorax, that was their story. And they said it all started when taking a shower. Do you have any idea if there is a correlation there, and if so, taking a shower has to do with?
Well, maybe it's like the warm air allows you to take deeper breaths. I don't know. Like if you've ever had a cold or something in a warm shower, you feel like you get a deeper breath. I don't know.
Yeah, I just mentioned it because it's still in all the textbooks we're using, and people ask me all the time, and I don't have any idea how it would make any difference. Okay, thanks for your time.
All right, so case 4. So 29-year-old female came in with EMS with chest tightness, shortness of breath, tingling in her hands and lips, sudden wave of fear. Her heart was racing. She thought she was having a heart attack. No prior medical history, no drug use, no meds. She's tachycardic, hypotensive or normotensive, breathing fast, O2 is 100%, afebrile. You still do all the things right. Like you look at the patient, you evaluate the patient, you get an EKG, and you interpret it the way you've all been taught. Sinus rhythm, normal access, no ST segment elevations or depressions, intervals look okay. You get a chest x-ray looks perfectly fine. And you finally get some labs, you get a troponin normal, electrolytes fine. Maybe she's calmed down a little bit, maybe not. This is probably a panic attack, right? So this patient came in very anxious, complaining of numbness and tingling to the hands, heart's racing, feeling like she's gonna have a heart attack. This is a panic attack. They can have palpitations, tachycardia, diaphoresis, shaking, chest pain or pressure, nausea, dizziness, paresthesias, flushing, or chills, right? They can have all these symptoms, and so can all these other bad things. So the big thing is to make sure that you're not missing the bad things. So the weird thing is that your panic attack, you can have chest pain, right? And this chest pain could either be non-cardiac related or cardiac related. So your non-cardiac related is when they're hyperventilating, they're having like musculoskeletal pain, those intercostals are breathing a lot. So you could have some esophageal spasms as well, but you can also have cardiac pain with panic attacks. So because they're breathing so fast and they're tachycardic, maybe they're having some microvascular ischemia around the heart. Maybe they're having a coronary spasm. I think about 22 to 70% of all panic attacks have chest pain. So again, we have to make sure it's not like cardiac chest pain, none of these other scary things, and then we can say it was a panic attack. Treatment for you guys is just do all the things. You've seen these patients, you've kind of had the feeling that it's a panic attack, but still do all the things. In the hospital, we're doing all the things, diagnosis of exclusion. Maybe I throw an Ativan or Versed or a hydroxyzine at them. If they're being discharged, I might consider doing an SSRI, SNRIs. Probably not. I'm probably going to have to follow them up with a PCP. But the summary for this case is don't get got, okay? Like, I'm going to get got, but I'm going to get mine before I get got, though. No one knows that? I thank you for laughing, at least. 55, case 5. 56-year-old male with severe chest pain that started suddenly after several episodes of forceful vomiting following heavy drinking. Pain is sharp, radiates to his back, worse with deep breathing, feels feverish. So he's tachycardic, hypotensive, tachypnic, little bit hypoxic, febrile. This is a picture of sepsis at this point, right? He's tachycardic, hypotensive, febrile. He's diaphoretic in distress, but he has emphysema and he was vomiting. He has diminished breath sounds in the left face, mild epigastric tenderness. He gets to the hospital, maybe you're in the back of the car and you start feeling on his chest and everything, and you feel like Rice Krispies. You feel snap, crackle, pop. You feel some cutaneous emphysema. You look at his chest x-ray, he might have an effusion in the base. This one doesn't, but you do see that subcutaneous emphysema around the neck right there. So in the setting of vomiting, chest pain, and the subcutaneous emphysema, I'm thinking Boerhaave syndrome. So this is typically following forceful emesis and retching. It's a full thickness tear of the esophagus, and you'll have this macular triad of the vomiting, chest pain, subcutaneous emphysema. This is a very high mortality. About 60% of these people will die, and 100% will die without any intervention. A lot of times it's middle-aged men post-excessive food or alcohol intake, and you'll have what's called Hayman sign, where if you like lean them on their left lateral decubitus position, you'll have like a mediastinal crunch when you're listening to the heart almost. I don't know if I'm ever going to hear that. Maybe I will, but I highly doubt you're going to put them to the side in the back of a vehicle. If you get a CT scan, you'll kind of see effusions in the back, and that's all the gastric contents coming back up through the esophagus, going into the pleural space right there. There's differences between Boerhaave's and Mallory-Weiss. I don't know if anyone's ever had like a severe illness where they're throwing up a bunch and all of a sudden they see a little bit of blood in. That's probably a Mallory-Weiss tear, so it's like a mucosal tear. It's not a full thickness tear. You probably won't have chest pain. You'll just have some of this blood. Their chest x-ray would be normal. The Boerhaave's is, again, the full thickness, very painful, radiates to the back, has the history of the vomiting and the chest pain as well. And again, very, very, very fatal. The treatment is, it's essentially they're going to avoid all oral intake for 7 days. You're going to do IV antibiotics. You're treating this as a septic patient, right? They're tachycardic, hypotensive, febrile. They're going to drain any fluid collection, and then the surgery portion, I believe most of these patients are probably going to get surgery, but I was looking at it and they sometimes observe some of these people and then decide to operate later. To me, I'd probably want to operate earlier, but essentially they are for sure going to surgery if the contained perforation turns into free perforation, if the injury itself extends, or if they have persistent fevers, meaning that they didn't get control of the source of infection. So summary of case 5 is your pain's going to be GI, your esophagus, that plexus around the esophagus. You're going to have some pleurisy when you have an effusion there, and you might have some cardiac chest pain as well if there's going to be stress on the heart from the sepsis. Take a good history, look for the macular triad. They had vomiting, chest pain, and subcutaneous emphysema, and then just resuscitate according, because this is going to have a picture of sepsis. So you will be given fluids, pressors if needed, antibiotics. Any questions?
On that one, with the evidence of sepsis, what kind of time frame you looking at, Doc? Does it happen pretty quick from the esophageal perforation to signs of sepsis, or does it take days usually?
I don't think it's days. Looking at some of the cases I was looking at online, it seems to happen very quick, and they'll develop mediastinitis. So those mediastinum compartments, they'll get inflamed, infected, and they have to be cleaned out.
Is there any correlation with are there any risk factors we know for this? Like
the middle-aged man, excessive food intake or alcohol intake is probably the highest risk factors. Is that your question?
Yeah, I was wondering if alcoholics were more likely to.
Yes. Yeah.
Thanks.
Yep. I think this might be the last case. So 67-year-old woman presented with 2 days of sharp burning pain across her right chest. Says it started near her breast, wrapped around her back. Pain is severe, constant, worse when her shirt touches her skin. No cough, fever, shortness of breath, cardiac history. Vitals are okay. She's afebrile, well appearing, but she appears a little uncomfortable guarding her right side. So again, you get there, you do all the things, you get an EKG. EKG looks okay. You transport her to the nearest hospital. They get a X-ray. X-ray's okay. Say I get all the labs and I do the troponin and everything looks okay, and I have no clue what's going on. This is probably one of the more embarrassing things, which hasn't happened to me yet, but you got to remember to look at your patients, right? So this cause of chest pain was shingles. So she has a rash extending from her back across the dermatome going to the chest, which is causing her pain. So if someone had just looked at her chest and saw this, probably could have saved a lot of workup and money, okay? Could have just started her on the antivirals. But shingles is essentially dormant chicken pox that lies within the nerves of your spine, and then stress or other things or an infection can cause it to reactivate. And when it reactivates, it follows this dermatome of wherever it's at in your spine. So I saw someone recently where it's around his belly button. It went around that way, so around like the T10 level. But you can't have it up in the chest. You can have it in the eye, the face, all over. One of the things I wanted y'all to know that if you do see this is kind of a contact and airborne precautions. So this can be aerosolized. So these patients, you want contact and airborne precautions until these lesions crust over, which is, I believe, about 7 to 10 days. So it probably would be a good thing to uncover and see, just so you know if I need to put a mask on, be really careful with gloves and everything like that, especially if you have kids at home. Any questions about that case? And that is it.
Hey, Doc, on the shingles, talking about infection control precautions, now people can catch chicken pox from somebody with shingles, right? But shingles doesn't transmit from person to person, is that right?
It's the same. It's the same virus.
Right, but I mean, if I've already had chicken pox, I have an immune chicken pox, I'm not going to get a case of shingles from being in contact with somebody that has shingles.
If you had chicken pox, you have the shingles, it just hasn't been activated.
Right.
Does that make sense?
Right.
So I guess you're right. You wouldn't technically catch it, but I guess you would be at more risk for it to be inactivated or something.
Yeah, if we think
I
about
still wouldn't go rubbing it.
I know it's the same virus, but when we think about it, the disease state, you get chicken pox from people with shingles. You don't get shingles from people.
Fair, but if you catch the chicken pox, then you will catch the shingles. Yeah, I see where you're trying to say. Yeah, yeah.
Very good lecture. Very interesting. I tell you that. I guess the main point I got all that was, patient has chest pain. We tend to have, or I'll speak for myself, I tend to breathe a little sigh of relief when I kind of determine it's non-cardiac. But really, a lot of these are very serious, and even if they're not life-threatening, complicated and
Yeah, I'll throw in, that makes me uncomfortable, that statement you made. Well, that one and the shower one made me uncomfortable, to be honest with you. But
okay. Nobody here is fully concerned.
Yes, sir, I'm aware of that too. That being said, great lecture, Doc. Super good stuff. Good application for both EMS and the hospital folks that watch. Just because you get a 12 lead on somebody and it doesn't look like a STEMI, still does not mean they're not having a heart attack, a cardiac event. Remember, there are STEMIs, ST changes on a 12 lead and heart attacks. There's also people having heart attacks that don't have an EKG change, and those folks still die too if we don't treat them. So don't assume it's not cardiac just because the EKG is normal. Definitely don't assume that because you got this person there with chest pain and you say the EKG looks fine, don't make the suggestion they probably shouldn't go to the hospital with you or shouldn't be taken care of, because that is poor form. Even me as a doc with a couple of years of experience here, if I got somebody with an EKG and a good story, I'm still doing labs and other things. And sometimes even when their EKG is normal and their labs are normal, I still put them in and watch them for 12 or 24 hours because sometimes we just don't know. No test is 100%. So yes, you can say you're having a heart attack with an EKG. You cannot say you're not having a heart attack or acute coronary syndrome with an EKG. On that note, the EKG can also tell you other things. So he mentioned pulmonary embolism. An EKG can give you information that makes you think of PE. That S1Q3T3 is great. The more common thing is just tachycardia, right? So you got this person that's tachycardic, hypoxic. The tachycardia is a big sign that the heart's under stress. The other thing you can look at, as we've talked about before in some of the 12-lead classes we do, is right heart strain. So the person that is now having a right bundle branch block, you have no way to know in EMS if they've had that before or not, unless we get shared data, which one day we will. But, a young person that's tachycardic, a little bit hypoxic, that has a right bundle branch block on your 12 lead should make you think as well pulmonary embolism, because that's right heart strain. Your EKG can pick up pericardial effusions like you talked about with that, what's the fancy name you said? Alterans?
Yeah, Alternans.
That makes me think of some kind of science fiction movie, but yes. You can pick that up. You can also, with your 12-lead EKG, pick up electrolyte problems. You can pick up if their K is high. You can pick up if their MAG is low based upon their QT. So an EKG gives you a lot of information, and put all that together to figure out what's going on. The other thing I wanted to mention was, what if you have someone that is, mid-50s, a guy's been smoking since 1970, he's got chest pain, he's short of breath, he's tachycardic, he says he feels weak, and he's got left-sided facial weakness and right-sided arm weakness. But he's also got chest pain. So you're doing your stroke assessment. You're thinking about putting him in the stroke system. You do your 12 lead because he's got chest pain, and that's just what we do, right? And now your EKG is a big freaking STEMI. So you got a guy having a stroke and a STEMI at the same time. What do you do with that guy besides pray for him? What system do you put him in? Do you call him a stroke or do you call him a STEMI? Okay. Yeah, well, yes, sir. Yeah, right. Yeah. And I'm kind of messing with you a little bit. So if you think about it, if you're having stroke symptoms, you got to think, oh, you're probably having a stroke. But then you get a 12 lead and you got a STEMI. Now you have a STEMI. So now you kind of hose, like, what's going on with this guy? One thing can cause both of those problems, and that's a dissection, aortic dissection. So that vessel, that aorta starts tearing, and it tears all the way back to the top of the heart, that aortic cusp, and it jacks up that coronary artery. So what you really need is you need a thoracic surgeon. So stroke plus STEMI at the same time is a dissection to prove it otherwise. If you had to pick one to go to, pick a STEMI center, because a STEMI center, like you said, has access to thoracic surgeons, because those guys that go in with those catheters to fix heart attacks, sometimes they make mistakes and they perforate things, make holes in places they should not make holes in. So they got to have a backup plan, and that backup plan is that thoracic surgeon. So good call. I would take them to a place that does both, but STEMI is the more important. But stroke and STEMI at the same time is probably a dissection, and that makes me as an ER doc think, holy crap, I'm calling cardiology, but I'm also on the phone to thoracic surgery, and I'm going to get a CAT scan of his chest or an ultrasound real quick to prove it's a surgical emergency to get him to the right place. That's somebody I would not give a thrombolytic to, because if I give them a thrombolytic to fix their stroke or STEMI, and it's really a dissection, I basically have just, I don't want to say I've killed the patient, but I pushed them in a direction that is not good for a complete recovery. How'd that sound? That was good.
Hey, Doc, you mentioned, and Dr. Kirby mentioned some uses of ultrasound bedside for doing things like determining pneumothorax. Is there a way to, an easy way, a bedside way, to see a dissecting aneurysm at bedside ultrasound?
Probably not the type A. The type A will be a little harder to see just because it's sitting right behind the heart. Their abdominal dissections might be a little easier to see depending on their body habitus, but it's probably not going to be something that's going to be used in the field to evaluate for a while. It might get there. What you're going to use the ultrasound for in a dissection is if you suspect that they have like a pericardial effusion or tamponade. So you throw it on the heart and you see fluid around the heart, and they had chest pain radiating to the back, history of hypertension, smoking. That's a dissection until proven otherwise.
Yeah, so it's not a direct picture evidence of it, but it gives you more data to put along with everything else to figure out what's going on, right? Just like chest pain alone is not enough to say you're having a heart attack, but 48-year-old diabetic, sweaty with a recent bypass, now having chest pain makes me think, oh, he's probably having another heart attack, right? So you kind of put it together. Ultrasounds, we don't sell them. I'm not trying to market these things to you guys, but they have some now that have AI that label things for you. So you put it on the heart and it labels anatomy, and it's like cheating. And it's a great way to give you information. And some places are using them now to help determine, do you go locally? Do we call the aircraft? Do we make that 45-minute trip to the bigger center? What do we do with that? Because you can get some good information with that. And with the way AI is going now, it can label it. So even people like me can do ultrasounds and figure out what's going on.
Very good. I see lots of uses and keep thinking of new ways that EMS will probably be using AI-assisted ultrasound in the field, and quite there yet. But
yeah,
I think in the not too distant future, it's going to be standard care
Yeah, I agree. Yeah, I think so too. Sort of like the 12 leads came to us, decades ago. I think this same thing. It's just the technology is there. It makes it so much easier. Yeah. Wanted to add one more thing when you talk about pneumothorax. Remember, a pneumothorax, y'all can be suspicious and diagnose it in the field. You know, increased work of breathing, hypoxia, asymmetric lung sounds, things of that nature. When you get to hospitals with these things, mention that to the doc when you get there. Sometimes they're going to roll their eyes at you and make faces, but that's okay. But that gets us, as a doc, gets us up moving toward that patient to make sure they're okay. The other thing to remember is we don't put needles in pneumothoraxes. We put needles in tension pneumothoraxes, and we'll probably talk about that in a few minutes. So I won't steal the thunder. But and some people who smoke long-term get blebs with their COPD or emphysema, and a lot of times they have diminished breath sounds, or you think they have a pneumothorax, and you start putting needles in them, you actually make things worse. So if you're doing an invasive procedure like a chest decompression, you should be scared and sweaty, think that patient is going to die in front of you before you start poking their chest. Poking is a medical term, by the way, poking.
Yeah, it's sweaty.
Sweat. Well, yes, sir. Fair enough.
Yeah. Very good. Thank you, Dr. Ferguson. Thanks, Doc. That was a great lecture. We're all going to take just a few minutes break, stretch your legs, use the restroom, whatever you need to do. If you're listening online, there's a link to the attendance form in the chat box. I originally posted the wrong password because I'm incompetent. I have corrected it. The password is actually, try to get it right, is chest. Password is chest, all lowercase. If you don't have access to that for whatever reason, you can send an email to alabamaemschallenge@gmail.com. Get an automated reply with a link to the form. If you're here in person, we'll put the QR code up for you in just a minute. So we're going to go away for a few minutes, but please don't go anywhere. We'll be back with Dr. Sullivan.
Good to meet y'all this morning, or maybe see y'all again. It's down here, I think, 2 years ago, doing EMS challenge over on campus. So good to see the ones of you that I've seen before again. Appreciate your time this morning and commitment to trying to learn something. So hopefully we can deliver something to you that you can take into the field today. Tyler Sullivan, I'm one of the EMS fellows with UAB and Birmingham Fire and Rescue. This is part of the EMS Challenge lecture series. I wish I had financial disclosures. If y'all have some spare cash, I'm open to it, so let me know. Today, we're going to talk about blunt penetrating mechanisms of injury to the chest and a little bit up into the neck. We're going to talk about thoracic anatomy that's critical to your assessments and kind of running through your differentials of what may have happened to this patient, what you're dealing with. We're going to work through some life-threatening chest injuries and recognition of those and appropriate interventions, as well as some potentially life-threatening injuries to the chest. And we'll talk about those rapid interventions that you can do in the field, and then the emphasis on transportation to the appropriate center. So reason why this is important, when this gets redundant today and when we talk more about things that cause chest pain, like we've already been harping on, just keep this in mind to kind of keep the frame here of how important this is chest trauma causes about a quarter or more of the total traumatic injury deaths, and up to a third of these are preventable with timely interventions. So when this gets a little bit mundane, just keep in mind that like upwards of a third of these traumatic injury deaths, like you can have a meaningful impact on with appropriate intervention. So emphasis here again on recognizing like tension physiology, doing what you can to stop bleeding or giving fluids back, and recognizing some of the more subtle and hidden injuries here. So obviously there's two primary categories here, blunt penetrating. They're going to present in different ways, but emphasis on kind of blunt injury. There can be more devastating injuries under the surface than their external exam kind of gives you. The penetrating traumas usually are pretty big red flags, especially when there's some big object sticking out of their chest. But the little gunshot wounds, you know that these things are serious and have probably resulted in at least some damage inside. So a little more obvious there. As far as blunt injuries go, these are MVCs, falls, crushes, explosions, things like that. People get hit in the chest with falling objects, with pieces of trees, hammers, all that kind of stuff. How that works is there is compression of the chest wall that causes contusions, so like bruises of the lung, bruises of the heart, damages the lung itself, poke holes in it, shears vessels. Your biggest blood vessel in your body, your aorta, runs through the middle of your chest and is very susceptible to injury, particularly penetrating. And we talk about things like pneumothorax, cardiac tamponade, things of that nature. So we'll go a little more into detail here. Penetrating mechanism, these are the gunshots. These are the people that are impaled by various objects, motorcycle wrecks into a fence, things of that nature. Particularly with gunshot wounds, they can cause small holes on the outside, but cause these big ballistic injuries on the inside, cause big cavitating injuries that can wreak havoc on the thoracic organs. The entry, exit, all that kind of stuff, we're not going to get too much into that, but know that those things aren't reliable and ultimately are not important. It's more important for you to just identify where the holes are and call those out. But essentially, the kind of flow of penetrating injuries as you identify, it's usually going to result in something along those lines of this chart here, like a pneumothorax, into tension physiology, or just in laceration of vessels or the lungs or things of that nature, resulting in either hypoxia or blood loss, reduced cardiac output because of obstruction or compression. And those are going to be your big kind of primary mechanisms of what you're going to see these injuries result in. So comparing the two, penetrating are usually more obvious or raise more red flags, right? With a gunshot wound to the chest, you're worried about all the bad things. With a blunt injury to the chest, there may not be a whole lot of external signs. So again, this is where you want to do a little bit more of a detailed physical exam and make sure you're not missing something underlying. A single rib fracture can cause a lung laceration and result in a pneumothorax that you develop tension and kills the patient. So a little more focus on physical exam in that case. Your blunt traumatic injury is going to account for the vast majority, particularly outside of places that are more prone to violence. So those numbers can be even higher. Penetrating injury is roughly only 10% of all traumas that we see at the trauma centers. So the key takeaway here is have a high index of suspicion for the worst possible outcome for the mechanism of injury. So a little bit about the anatomy. We'll just go ahead and skip into the schematic here because it's busy. But basically, you've got heart, lungs, you've got the great vessels, your diaphragm, sternum, ribs, spine, all locked into this box. And as you can see, there's a lot of stuff going on there. So coming in and out from your shoulders, you've got your subclavian artery and veins. You've got your superior vena cava, the big vessel there on the anatomical right of the chest, your left. Your aorta is running kind of posterior back there. Your trachea, esophagus, all of that running down the posterior midline, and obviously your thoracic spine back there in the back, and then your big fat heart sitting there right in the middle. So a lot of stuff going on there. It's hard not to hurt something if you get a penetrating injury to the chest, obviously. And blunt injury, there's a lot of potential for bad stuff going on there. So a lot of vital organs, a lot of vital vessels and things of that nature that are here in the heart. So this is kind of why we put a little more emphasis on this. So key surface landmarks that you guys need to know stone cold: the second intercostal space in the midclavicular line, the anterior axillary line in the fourth and fifth rib space, as well as the mid-axillary line in the neurovascular bundle, as Dr. Kirby alluded to in his lecture before, runs on the inferior portion or the underside of a rib. So if you're ever doing a needle decompression, you need to make sure you're going over the top of ribs. So your mid-axillary line, if you have the patient lying supine, I like to have the patients, if you're doing anything over here, particularly if you're going to decompress a chest, I like to have their arm pulled up as able. Sometimes they have shoulder injuries and things like that that prevent it. But pulling this arm up really exposes that kind of triangle or I guess that's more of a square there, but it's more of a triangle here of pec muscle that really decreases some tissue. You get down to the chest wall a little bit easier. But pulling the arm up also kind of widens those rib spaces a little bit and can help you identify your landmarks. But essentially, the way I find the appropriate place to do like a needle decompression here is to find the nipple line and go straight down, find a rib, and go over the top of that rib. So as long as you're heading north in that nipple line, that's kind of where you want to be. Midclavicular line, the way I kind of go about that is find the clavicle. I feel down. I press really hard and go down one space until I feel the next rib. That is your second rib. And so go right over the top of that. Midclavicular line, you just kind of estimate where the middle of that is, right? So good schematic there. Big on our Schwarzenegger, in a good position for a needle decompression there. A little more tissue, so you might need a little bit longer needle, I'd say, for that guy. I put this in here just as a kind of to put a point of emphasis on this too. So the reason that we identified these landmarks is to avoid the heart, liver, spleen, and hitting an organ that you don't want to put a needle in, right? Your liver and spleen are always higher than you think. Your diaphragm is always up higher than you think. So if you're in that mid-axillary line doing a needle decompression, I would say if you're going to make a mistake, I want you to make it up a little bit higher rather than lower. As you can see, like how many rib spaces up is that liver there? That's probably 5-6 ribs up. So if you ever go to a cadaver lab, if you're ever in there with one of the bodies that's been opened up, you can really see how high that liver is sitting. So those things are always higher than you think. So keep those things in mind. Every time we talk about our ABCDs, we like to have structured algorithms, even in the trauma bay, where we do this hundreds of times throughout our residency training. When you're in a high stress situation, particularly when you have a critical patient that has some kind of traumatic injury in the field, you want to have this structured assessment approach to where, like, the way I look at this is I want the least amount of thinking that I have to do as possible so that all of my kind of brain space can go towards figuring out what's wrong and the appropriate intervention. So I want all the noise taken away. So I like to have these standardized protocols and just remembering your ABCs, airway, breathing, circulation, and then your disability and exposure. That helps me kind of block out a lot of the noise and get through what I have to see in order to make the right decision. So the life threats when we're talking chest trauma, airway obstruction, and that gets a little bit more into the neck, but we'll talk about it as our first point. Tension pneumothorax, open pneumothorax, or like a sucking chest wound, a massive hemothorax, flail chest, cardiac tamponade, and then injuries to the great vessels. So first on airway obstruction, you'll see this a lot of times in neck hematomas and things. And I want to make this point, which is why it's kind of the first picture on the right there, or on the left, is a lot of these patients that have a high mechanism blunt injury, that hematoma does not start large, right? It starts very small and expands. And what are you guys typically doing when you have a patient with a high mechanism MVC? Probably putting a cervical collar on them, right? And so that will obstruct your view of the neck. So these things can be sneaky. These things have snuck up on us. I've seen it happen in the trauma bay with multiple doctors running around taking care of patients. There was an elder lady about a year ago that had a big subclavian injury, she had a big subclavian vein injury that just leaked out slowly. She had a cervical collar on, and until she got into pretty good respiratory distress, and we had a pretty tough time getting an airway because it had shifted her trachea over so bad that we had to use a bougie just to thread past it and a lubed up tube so we could slide it down a C-shaped trachea. So very important to be conscious of this, especially if you're putting a cervical collar on someone early, that those things can happen. Obviously, penetrating neck trauma is going to, cause you tracheal injuries and things like that as well. Those are typically more obvious. But what you're looking for in these patients is developing respiratory distress, stridor, so noisy breathing, gurgling the respirations, snoring respirations, and things of that nature. How you're going to manage that is keeping their airway suction, so trying to keep secretions out, assisting their ventilations as you need to, so NPAs, OPAs, BVMs, LMAs, all that kind of stuff, intubation and surgical airways as needed here. If you have a good expanding hematoma, it's not a bad idea if you're RSI to go ahead and take an airway before it gets bad, because it's going to do nothing but get worse. Those patients typically require surgery. So tension pneumothorax. So essentially what happens is your chest it gets a new aftermarket one-way valve. So a gunshot wound to the chest where the negative pressure of an inspiration is drawing air in, and then the various tissues are kind of plugging up the hole, so you're pulling air into it. Or you get this from a lung injury where air is coming in from the top and it's leaking out and getting in between the spaces between your lung and chest wall. So what it does is it can be subtle for a long time, have very minimal effect on the patient other than shortness of breath until it's not. So it builds up enough pressure inside of the chest to where it starts to move everything over. It puts pressure on your heart to where it exceeds the filling pressure of your heart. And so once that happens, you start to poorly perfuse the rest of your body. Your blood pressure starts to drop, oxygen saturation start to drop, and you get into trouble. So that is where it's critical for you guys to recognize a pneumothorax and needle decompress the patient. So as we talked about, that's where your landmarks in knowing those cold. Even on bigger patients, we know the Alabama standard is sometimes not your classic, 180-pound male. Sometimes these are 300-400-pound people that get into accidents too. So being able to parse your way through some obscured landmarks is of importance here and can save a life. So once you needle decompress, these things are not reliable. There's a pretty decent fail rate, not because of skill, but because of equipment. You're putting a needle into the chest and most of the time leaving some kind of plastic tubing or catheter that doesn't always hold up. So don't be afraid to do multiple decompressions if you've decompressed once. So once you've identified a tension, or once you've identified a big enough pneumothorax where it's having an effect on a patient, you've made a decision to do a needle decompression. Don't be afraid to do it again, especially if they start to develop the signs and symptoms of tension physiology. So here, this is kind of just a schematic of what happens, but on the left there, that is what we would see on initial chest X-ray in the trauma bay. So on the right, you see all those little spiderwebby, cobweb-looking things that would indicate pulmonary vasculature. On the left, there's a bunch of dark space, and then this blob thing. The blob there is basically just collapsed lung, and all the rest of that is air where it's not supposed to be. So same process, sucking chest wound. This is one that you may see in a big, kind of large caliber ballistic injury, but a variety of mechanisms can cause this. And essentially, the only difference is you're assessing this patient, and every time they breathe in, you're hearing air move through the chest wall. So a lot of times you'll see a penetrating injury that has a lot of bubbling or is making racket. So immediately what we'd want you to do is slap a 3-way or whatever chest seal that you have. What it does is it occludes the wound with negative pressure, and when positive pressure returns with like an exhalation, it forces that air out. So that keeps air from going in, and it allows air to escape. So timely recognition and getting the chest seal over those wounds is very important. And that also puts a point of emphasis on physical exam and making sure that you're finding all these holes. Getting a good back exam in a patient with a penetrating anterior chest injury and making sure you're not missing something like this that you could slap a seal over and potentially prevent a bad complication. So tension pneumo, identifying a penetrating chest injury, putting the seal on it, needle decompression as needed, and then they get the chest tube when they get to the emergency department. I put those on there just because they're pretty good landmarks there. You see the one on the right is right down in the nipple line, and the one on the one on the left and the one on the right is a little bit higher where I like to have it. Critical point here. If you are ever considering intubating one of these patients, so you've developed tension, the patient's minimally responsive or in bad distress, and we're going to take an airway, make sure that you're adequately resuscitating this patient before. So what do you guys think is going to happen with a patient that has a blood pressure of 65/40, is in respiratory distress, and you decide to intubate them and put in a chest tube? So you put in that tube, you increase the pressure even further in that chest, and now you've completely taken away the heart's ability to refill and sometimes to pump out as well. And so now the patient's going to code. So if you have one of these patients that's hypotensive, that you think is tension or you think is blood loss, make sure you're intervening on what's actively killing the patient then. So needle decompression, getting blood, fluids, whatever you have for volume resuscitation before you consider putting more pressure in that chest. We'd like to see a better blood pressure in that situation. So use of even like push dose pressors is reasonable, like push dose epinephrine. So making sure that we're resuscitating before we consider intubating these patients, particularly in trauma.
Cool. I'm going to throw a few points in. Great job. Just a few things to think about. He talks about the RSI. This is for the guys, the critical care guys mainly, but for everyone. When you think about RSI, taking someone's airway who's hypotensive and trauma can kill them. RSI stands for really sucks to intubate them, is my joke on that, right? You got to think more resuscitative airway. So if their blood pressure is low and they're altered, not breathing good air, and you take that airway, you're going to drop that pressure. You got to volume resuscitate them. So places that are doing RSI and trauma, you got to have blood products because saline LR is not going to do that. We use push dose epi. Some of the flight crews use neosynephrine to kind of bridge that gap because they got to get them on board an aircraft and you can't tube them in the aircraft. I get that. But you still got to start the blood. You got to get that blood pressure up or you're going to kill the patient. If they have a tension pneumothorax, you got to get that needle in there before you do positive pressure ventilation. State also says if they have a flail chest, so they have multiple rib fractures, crepitus on the chest wall, and you're going from passive O2 to bagging that person, you can pop their chest. I know the classic definition of a flail chest is you got segment of ribs with two different areas where the ribs are broke and paradoxical chest wall motion. In reality, you don't see that for the first 30, 45 minutes, an hour past trauma because that muscle spasms and it kind of splints that flail segment. So my thought is if you got a guy that's got massive chest trauma, they got crepitus, the chest is tender, they're moving, they're altered, and you're going to start ventilating them, you start thinking, clinically, I think they probably got a flail chest, and you decompress them. Because they do have a pneumothorax, and you start bagging that person, it's going to get worse, and they're going to arrest on you. So an airway is needed of these people, but it's also high risk, so be wise. The other thing I want to put out there, a train. I like trains. That's pretty cool. Yeah. The other thing, you think about chest seals. I know that we've taught that forever. Let me give it a second. I think we're there now. Oh, I got burned.
No, he's going to get you.
Good. And he get me, yeah. I think I saw Thomas go by. I don't know. So chest seals, great idea, works great. However, they were designed for young, healthy military people, right? And like the doc said, a lot of our patients are not that way. Point to this is, if you got a very chunky person, they're shot in the chest or have chest trauma, and they're bleeding through a hole in their chest, and you just throw a seal over it, and you got 3 inches of subcutaneous tissue between the chest seal and the thoracic cavity, they can have vessels in that subcu that are just pumping blood out. So sometimes it's reasonable to put your finger in the hole or pack that chest wound to stop the bleeding in the subcu area. I am not saying that you want to put 8 yards of combat gauze into somebody's chest, okay? What I am saying, if it's a chunky, obese person, sometimes you got to stop that bleeding that's superficial because every little bit of blood they lose is important. If they're missing a huge piece of their chest wall from a shotgun blast or something weird, and you see a little squirter pumping out, You got to stop that bleeding, because if you don't, there will bleed out just like you can bleed out from a scalp lag. So chest seals are great. I'm not saying don't use them, but I'm saying look at your patient and determine, do they need a little bit of combat gauze, maybe some 4x4s with TXA or some cling or something in addition to that seal to make sure we control bleeding that's external of the chest cavity. Does that make sense? Cool. All right. Thank you, sir. Sorry.
Cool. No, that's perfect. So yeah, resuscitate before you intubate. Next up, hemothorax. So don't worry about the numbers. This is where a very large amount of blood accumulates in the chest wall. Usually these would not be super significant for y'all if it is a hemothorax alone and it's small volume. This blood will collect, but they should not develop any hypoxia or anything of that nature. But as these things grow, so if they've lacerated like a major pulmonary artery in their chest and they start to really fill up with blood, it can behave in the same way as a tension pneumothorax. You get tension hemothorax, where the pressure builds up enough where it starts to compress the heart. Same thing. The key difference here is that their chest, if you were to percuss it, which you're not going to do, would be more dull. And if you decompress with an open bore, like an 18 gauge needle or something like that, you get a return of blood rather than air. A lot of times the pneumothorax and hemothorax are living together in there. So decompression is still the answer. If you have a patient in distress and has decreased breath sounds on a single side, I would go right for it. But if you get a huge return of blood back, that's something that you want to communicate in the emergency department. But again, this is O2 rapid transport and volume resuscitation if you're convinced that this is mainly hemothorax, but manage it in the same way as you would a pneumothorax. So on the flail chest, as we were talking about, this is typically defined as 2 or 3 ribs broken consecutively in at least 2 places. So you get a free floating segment of the chest wall. Like you were saying, like we see plenty of flail chests. Technically, they call them flail segments on CT scan because that's when we find them. They'll have a bunch of ribs broken down through, but their chests aren't moving paradoxically. When you do see that, it's horrifying to see, because when they take a breath in and they pull that negative pressure, they pull a big divot into their chest, and then when they exhale, they blow a big bubble out of it, which is crazy to see. But like you say, most of the time their chest walls are really insulted, so they're spasming down, and you don't see that motion. But you will see on palpation of the chest, you could feel chest wall instability. The patients, it hurts really bad, so they're taking very, very shallow breaths, and they get into respiratory distress pretty quickly. The management for these guys is once they start to, again, develop like a tension physiology or somewhere that you think they need needle decompression, go ahead and decompress these patients. There's some schools of thought about stabilization and try to help these patients out, but like compressing their chest is not going to do them any good. So I would not worry too much about stabilizing a flail segment whatsoever. But if you're in any situation where this is going to be more of a prolonged transport, I would worry about pain control for these people to help them adequately ventilate. Because most likely, if they have a big flail segment, they're going to have pulmonary contusions or big bruises on their lungs. That's not going to help them exchange oxygen. So helping them adequately ventilate and helping control their pain is important here. Positioning the patient could be also helpful in this situation. Anything that makes the patient more comfortable, so long as they're stable. But again, monitoring for tension physiology, decompressing as indicated. I hope this video works, because this is like the best example of it ever. Yeah. They look to be on a, if I'm like assessing the background information, it looks like they're wearing swim trunks and they're on a boat. So I'm assuming this is like a water sports injury or something along those lines, but that dude is in a bad way. I think he just pointed to where it hurts. I think we could parse that part out. Anyway, yeah, bad deal. Yeah. So I don't wish that on anybody, but that would be cool to see out in the wild. Hadn't seen that one that severe yet. Tamponade. This one's a little more difficult to parse out in the field without ultrasound. Now, if ultrasound becomes more of a widespread thing, which we think it will, this might be something that becomes more easily identified. So I included some ultrasound findings. So essentially what this is you would see this resultant from a blunt anterior traumatic injury to the chest, resulting in accumulation of blood around the heart. As it fills inside of an intact pericardial sac, same thing as the tension, right? It's more pressure pushing in on the heart than the heart can push pressure into it to fill. And more pressure than it can cycle that blood through and get it out. So once you develop that compression, you start to lose perfusion, lose your blood pressure. One thing that you find because of that is this thing called Beck's triad. So you see the vessels in their neck, their jugular veins start to become distended. So if you're seeing someone that has hypotension, they have big, thick jugular veins, they have muffled heart sounds, which you may not, all heart sounds sound pretty muffled on the back of an ambulance. You see those things in the setting of an anterior chest injury. Think about tamponade. The way we manage that is you guys aren't going to do a pericardiocentesis in the field, I assume. So that patient needs to get to an emergency department where that is available ASAP, because that blood's got to come out. And if not, it's going to further accumulate, compress, and that patient will code. So we move on to more of potentially life-threatening. So to kind of fill up the life threats, that's pneumothorax, hemothorax, tension physiology, flail chest, injury to great vessels, tamponade. The potential life threats are the pulmonary contusions, tracheal injuries, blunt cardiac injuries that cause arrhythmias and things like that, traumatic aortic disruption. Those are certainly life-threatening in the appropriate setting, but they either die on the field or they're a partial tear or something like that, and they make it to the hospital. Diaphragmatic injuries and esophageal ruptures. So contusions, and these we won't spend a whole lot of time on just because there's not a whole lot of interventions that we can do in the field. And honestly, they're going to be almost impossible for you guys to identify without CT scans, x-rays, and things like that. So a contusion is essentially a lung bruise. This is very common in pretty much any high mechanism chest trauma. And all it is just a bruise on a portion of the lung. Now, these can be so severe that the patients can't oxygenate. They do get bad enough to where they get intubated, go to the TBICU at UAB, and you can't oxygenate them. You can give them 100% oxygen through their ET tube, but their lungs are so badly bruised that their O2 sats are 80s, despite all the oxygen in the world that you could give them, just because that lung is so upset. That usually is a thing that develops, later after the injury. So it's not something that you're going to typically see in the field. Now, if you pick up somebody from their house that had a car wreck 2 or 3 days ago and they can't breathe, it's something to think about. But the only interventions we have here in the pre-hospital setting are going to be supplemental oxygen in various ways. So treating the hypoxia. Tracheobronchial injuries, rapid deceleration, so seat belts up on the kind of lower portion of the neck, blunt traumatic injury and penetrating injuries. Essentially, air is escaping into places that it shouldn't. So on the left there, you've got a good picture of subcutaneous emphysema. In the middle, that's a CT scan showing subcutaneous emphysema pretty much everywhere. All of the bright gray spaces, let's see if this laser will show up on there. It will not. But all of the bright gray spaces are kind of your normal subcutaneous tissue, and all of the black spaces up around the shoulders, on the edges of the neck, that's all air that's escaped through there and it's gotten in all those tissues. Those patients are very crunchy. You touch them, they feel like plastic wrapping or tinfoil or something or whatever you want to touch that's all crinkly. It's really strange. And they get it all up in their eyes. They get it all down through their pretty much all of their chest and thorax. We've even seen scrotums blow up at big air balloons. It can get really crazy. These are bad. So those have got to go to the hospital, go to a trauma center for surgical intervention. Those have to be fixed. Blunt cardiac injuries, these are relatively more common. So you bruise the anterior portion of your heart. Say somebody has a high-speed MVC, hits the steering wheel, gets a big fat bruise on their heart, what it can do is get so bad that it impairs the electrical conduction through that part of the heart. And it can essentially mimic like an MI. So there's a portion of the lungs muscle that's not working as well as the rest of it, which is essentially what happens when you have an MI. You lose blood flow, right, from a clot or whatever in a coronary artery. You start to lose function of that heart muscle. It gets ischemic and it dies. Same kind of thing can happen in bad blunt injuries. And what is the risk of a patient having a heart attack in the field with you? Is that they decompensate into like a ventricular arrhythmia, right? So if somebody has bad anterior chest trauma, like have cardiac monitoring on them for this reason. If the patient has a bad blunt injury and goes into cardiac arrest from an arrhythmia, that may be something that you can intervene on. So any patients that have bad chest pain after an anterior mechanism, have them on cardiac monitoring and be thinking about these things. Aortic injuries, these are going to be essentially impossible for you to identify without the use of some kind of imaging modality. But essentially the way this occurs, a couple of ways. So the most common is going to be like a shearing injury. There's this little ligament that helps hold the whole aortic apparatus because it comes up out of your heart. It has an arch to it, so it goes over before it descends. There's this ligament that holds it in place like a seat belt called the ligamentum arteriosum. If you're going 70 miles an hour down the highway and you hit something and you stop, everything in your chest is still moving forward, right? So the whole aortic apparatus itself shifts forward, and that seat belt is sitting on top of the aorta as it kind of makes that arch and goes down. And so it pushes up against it and it can rip a hole in it. And those patients bleed. If it's a full thickness tear, like they die. They die quickly. But if you get a little partial tear, that might be something that you watch for like development of tamponade physiology, where they get that compression, they bleed into the pericardial sac. Other mechanisms is just torsion. So if there's more of like a side mechanism, things like that, they can twist and do essentially the same thing. You can get bad sternal breaks that go back and penetrate the aorta itself. You can also have bad thoracic spine injuries that shoot bony fragments into the aorta and rupture it that way. Those people have massive internal bleeding, so they develop hemothoraces and things of that nature. Like I said, hemopericardium, they develop tamponade and things of that nature. Diaphragmatic injuries. If you ever put a stethoscope on someone's chest and you hear bowel sounds, this is something to consider. Essentially a high impact to the diaphragm or a penetrating injury violates the diaphragm, so you wind up with this hole. So the stomach rises up into the left chest is the most common way. The right side of the chest doesn't typically do it as much because there's a big liver sitting there and the liver's solid, so it doesn't necessarily move up into the chest quite as easily. But the left side, you can get the whole stomach and things like that to move up into the chest. It can get bad enough to where you get what's called a tension gastrophorax, which is a well-documented thing. And on the picture on the right, you can see the large gastric bubble that's up in the chest there. And those contents can compress the heart as well. So that can be a problem. Again, there's not a whole lot to do about that. If you see it, and I don't know how you diagnose this in the field unless you just suspect it and that it may be there, but treat it in the same way as tension, right? So the worst outcome of this is going to be tension physiology. Decompress the chest in the same way. Esophageal rupture, these are bad. These people also get sick and die. A lot of times we find this, or pretty much every time we're going to find this on CT scan. These patients can also kind of fly under the radar and get really sick from all the gastric kind of bugs that live in there that leak out into the chest. They get bad infections. Not a whole lot of ways to see these out in the field, but something that is there and does exist. So essentially, to bring all this kind of back, so have your ABCs, right? So we're thinking about in stressful situations, how can we make this more simple? Airway, breathing, circulation. So like clearing the mouth of secretions, blood, vomit, anticipating compromise for mechanisms of injury and suspected injuries in the chest. And if we're moving to give positive pressure of any sort, think about, is this patient adequately resuscitated before I add more pressure and potentially cause more issues? Breathing. So we're listening to both sides. We're listening for decreased breath sounds. We're intervening on those. We're putting chest seals on wounds. We're decompressing when indicated. We're providing supplemental oxygen and airways as indicated. In circulation, we're looking for external bleeding and junctional sites. We're packing wounds. We're making sure that we're doing everything that we can to establish IV access to get blood products or TXA or fluids or whatever you have available on board, and keeping it simple. I like the March kind of framework that the military uses. This is more of like I guess a tactical side. They focus a little bit more on the massive hemorrhage before, because obviously, like, if someone in the military or law enforcement on scene in a big, gunfight is bleeding to death, like, it's not sensible on scene to intubate this patient under gunfire, right? So they're focusing more on massive hemorrhaging first, but then they go into the ABC. So it's essentially like an MABC. Massive hemorrhage, then the airway, breathing, and circulation, and keeping the patient warm. Focused chest exam. So I want you to expose the entire chest. I want you to look along the back, making sure that we're not missing something. If they have 3 holes in the front, let's make sure there's not 3 to match in the back or in the armpit or somewhere that's hiding from you that may be contributing to the physiology that's going to kill the patient. Not really an entry-exit type thing. This is more of just labeling holes. That kind of stuff doesn't necessarily matter. Bullets do weird things in bodies. They bounce around and do things that you wouldn't expect them to do. Looking for paradoxical movement in the chest if you were to identify a flail segment. Palpating for crepitus, feeling for that Rice Krispie up around their neck and on the chest wall. Auscultating everything, feeling for pulses, making sure our pulses are equal in our upper and lower extremities. Putting on seals, decompressing, and reassessing the patient frequently. We've talked through these extensively. Needle decompressions, oxygen, all the goods. Load them and go. Do your immediate interventions. Don't let anything delay you from transport in critical or unstable patients. You can continue those interventions en route, and don't be afraid to needle decompress again. So take home, just understand that the anatomy is extensive, and that in the chest there's a lot of bad stuff that can get damaged. In blunt mechanisms particularly, anticipate that one of those things is jacked up. So be on the lookout for the big killers. Run through your ABCs and run through them time and time again as you transport, especially if this is going to be like a 15, 20, 30-minute transport. Reassess every couple of minutes. Your interventions can fail. Needle decompressions are known to be less than reliable, so don't be afraid to pull the trigger again if you feel like they need it. So, cool. Lunch is here.
Very good, very good. Thanks, Doc. I've got a couple of questions for you. One, on the topic of needle decompression, we've had a lot of people have had the experience, like you said. Oftentimes it's not a tension pneumothorax, it's both blood and air, or mostly blood. That blood will clot off that catheter after just a couple of minutes. So what do you do if you know it's clotted off? You heard the hiss, patient got better, now it's clotted off, patient gets worse again.
Yeah, so do it again. And you have the option of 2 different locations, right? And positioning. So if you don't think this patient has like a critical spine injury or something like that, you can help yourself if you're decompressing, like however your protocols are. If your protocols are anterior midclavicular line or mid-axillary line or whatever, if you're going mid-axillary, for example, you can kind of cock the patient over just a touch on that side. So what that will do will shift the air. The air will rise, the blood will fall, and hopefully you can separate that out a little bit more and just do it again. That's kind of the advantage of the midclavicular line, is gravity's there to help you and move that blood to a more gravity dependent place and move your air up to where your needle's going to be. Just do it again.
Gotcha. So you also mentioned EKG changes on a couple of the injuries you talked about.
Yeah.
So I know I've seen examples before where people were aware enough to do like continuous 12 leads for patients with chest trauma, and you could actually see ST elevation from myocardial contusion. Is there a lot of value to that to EMS, do you think? And would you think on a 12 lead you might see right heart strain for pulse?
You could. I think there's value in it in that, one, it keeps you more of a close monitor as far as arrhythmias go. So you're catching, you have eyes on for development of like of a lethal arrhythmia, right? Also, I mean, if you identify that this patient has like some subtle SD depressions or elevations kind of diffusely or in a pattern that would be consistent with like an anterior myocardial injury, you can get the inpatient team, because the hospital is not perfect. Like they may not recognize that on the front end. So you having an index of suspicion and communicating that after you've dropped the patient off, be like, hey, like I noticed some EKG changes too. That might tip off a doc who's busy or whatever and may have overlooked that or not be thinking about that in the moment to think like, hey, I need to think about blunt cardiac injury. So I think there's utility.
Yeah, always, if the phrase is, if you see something, say something. So if you as a medic think something's going on with your patient, even if you can't confirm it 100%, tell a doc. Now, again, it's like marriage. They may roll their eyes at you and call you names, but it's okay, all right? If you're concerned about it, speak up so they can further investigate, all right? Also, who here has seen somebody have a low-speed MVA and then go into cardiac arrest or have a STEMI? Remember, folks can have heart attacks first, and then their cardiac or their injury as well. It kind of limits the care we can give them. So if they had a STEMI or heart attack and they pass out and have a car wreck, we really can't give them blood thinners to help their heart attack because they may be jacked up from their trauma. So it kind of limits some things. I had a couple of questions too that got by text. One was from the previous lecture, pulmonary embolisms and capnography, you intubate them. Remember, if somebody has a huge pulmonary embolism, the area of the lung that has that PE is not going to do gas exchange. So they may have a low end tidal CO2 when you get them intubated. So just food for thought for that. The other thing I wanted to mention is, we talked about ruptured esophagus or perforated esophagus earlier. One of the more common causes for that is what he talked about, GSW, stabbings, things of that nature. And that's something that on us as the hospital, we got to find those things, because even if we save them with our chest tubes and our blood and our surgery, our perforated esophagus is bad long term. These guys can die from that. The other red flag that is not trauma related for a perforated esophagus would be, I've been having this GERD for a couple of weeks. I went to my local doctor and they sent me to the GI doc and they did a scope on me yesterday. Now I got bad chest pain. Well, we just put a tube the size of a garden hose down their throat. So we may have perfed that ourselves. And I guess my last thing I wanted to say is use every patient encounter you get as a learning tool. So every car wreck that you take care of, every patient, evaluate, listen to the lungs, palpate the chest appropriately, okay? But do your exam so that way you know what normal looks like. So when you have someone who's critically ill or injured, you recognize, hey, this isn't normal. Now you can start going through your thought process of what could this be? Is this a rib fracture? Is this a flail chest? Do I think there's a pneumothorax or a hemothorax? Do I think that there's a pulmonary contusion? And that way you can work with that, okay? That's all I got.
Very good. So one other question, and this one's of course loaded, is there's been controversy over decades about what the first aid should be for a flail chest segment. And my answer is there is no first aid for a flail chest segment. But for years it was taught to put heavy, bulky dressings on the outside to help the chest splint in one position. If you've ever tried to do that, it's pretty obvious it doesn't work. And then came along this idea that everybody with a flail chest should be intubated with positive pressure ventilation. Somehow that internally splints the fractured ribs. That doesn't make a lot of sense to me either. Any thoughts one way or the other?
No, I think in this setting, like pre-hospital care, I think you intervene on what's going on in front of you. So if you have a flail segment that you notice is developing tension physiology, intervene just as you would for a tension pneumothorax. If they've developed hypoxia without the hypotension, intervene as best you can on the oxygen, however that comes, whether that's assisted ventilation, non-breather, whatever. to treat that hypoxia instead of, considering those things. I don't think, in our setting there should be early intubation or a splinting of the chest wall or anything like that. Because I think in a patient that's critically ill and in distress, like further limiting the ability of their chest to expand is going to do nothing but hurt them. And, I don't know particularly anything about that would suggest that intubation immediately is going to help them in any way either. So.
Yeah, the key thing is recognize it, right? So they have a mechanism of injury that makes you suspect it. Then they got a clinical exam that makes you think, oh crap, that's probably a flail chest. The big concern thing is the underlying injury. It takes a lot of force to cause that. So you're going to suspect a pneumothorax with a potential future tension. You're going to suspect a hemothorax. You may suspect a pulmonary contusion. And I would bet my $7 I got left for the month that they're going to have a pulmonary contusion and be hard to oxygenate, right? So you treat the symptoms. So if they're a little bit tachycardic, a little bit hypoxic, get better with O2, but still look like crap, you're still going to do your O2, IV access. They're probably going to be tacky. You may do your TXA. You recognize the injury and you move toward a trauma center. If they become altered and drop their pressure, you're going to think, flail chest probably has a pneumothorax. Now they're altered hypotensive. I think they may have a tension. You're going to pop them. So you treat based upon the symptoms they present with. In the hospital, it depends on where you are. So sometimes once we make sure there's no significant surgical intervention needed, we replace the blood volumes, put a chest tube in these folks. They're still having a lot of pain. Instead of intubating them, we may call anesthesia down to do a nerve block or do things of that nature. So there are other things we can do, but it's all based upon how that patient looks and what can potentially kill them. So even in the ER, we're doing the same ABCs you guys do. We just add different diagnostics and tools that we can do to take care of that patient. In the intensive care, they're doing the same thing, the ABCs. They just have more tools, more diagnostics, more access to different therapies that we don't have in the ER. So it's this circle of life, maybe? Is that what that is? I don't know.
Okay. All right. I was with you. It's great
Until
answer
that.
right up until the circle
Okay.
of
All
life.
right. Yeah. Maybe it's the shower of life.
Sure.
Okay.
Yeah. All right. I'm gonna. We had some questions come in actually from Dr. Kirby's lecture. So one of the themes of questions is when you talk about blood pressures being different from the right and left arm as an indication of a dissecting aortic aneurysm, what kind of difference are you looking at? Is it a noticeable difference in app? Is it primarily systolic or does it matter?
I would say it's a noticeable difference in the setting of the full picture, right? Chest pain going to the back, history of hypertension, smoking, 50, 60-year-old, acutely happened. I take their blood pressure in both arms, and there's a 20 point difference in systolics on both sides. Or maybe one arm is like, don't have a radial pulse, it's a little cooler than the other arm. Those type of things. It's not like a 5-point difference or something that could have been like user error or anything like that.
Okay, I think you have a lot more confidence in our ability to take a blood pressure than you should. But so noticeable difference would be kind of
Yeah,
the answer.
Yeah, because the thought behind that is that dissection flap essentially occludes or causes a partial occlusion or decreases flow into the subclavian outlet, so you're getting just less perfusion out there. You can see it plenty of times, and if you do see that, if you see like a 30-point difference, like that should be like, we got to get a CTA.
And the dissection, they could have a dissection that doesn't involve that. So just because they have equal blood pressures on right and left arm does not mean that they do not have a dissecting. All right, very good. So the other one's a little weird, probably controversial. I doubt that y'all want to answer it, but I'll ask it. And that is, how safe is the shingle shot? I'm not sure where that came from, but any thoughts?
Please refer to the CDC for the risk to benefit brochure they have on that, sir.
Okay.
Fortunately, as an ER doctor, we don't have to give shingle shots, and Dr. Ferguson is the only one in the room that's old enough to get it. So,
shots fired.
Okay. I'm glad you're working all weekend, sir.
Really appreciate the lecture, Dr. It was a great talk today. Hey, Dr. Ferguson, where are we going next? Oh, you already talked.
Yeah, we're at a state conference.
That's right.
That's right.
Conference is the
Yeah.
next stop.
It sure is. And then we're back in Birmingham at Birmingham Fire and Rescue Station 1 in December. There's just one class in December. But our January through May dates are posted. They're on Facebook and should be on the Fire College website as well. And then hopefully we'll have the rest of our schedule for the rest of 26 up after the state conference. So Cadaver Lab sometime in December, probably the first couple of weeks of December as well.
Very good. Please remember to fill out an attendance form if you haven't already done so. The link to the attendance form is in the Q&A section if you're watching via Microsoft Teams. The password for the form, which is the first question, is chest. I originally posted that it was heart, but that was incorrect. And if you're here in person, we'll give you a QR code to scan to fill out the form. Once you fill out the form, you get your certification back in the email. If you don't get it back, you might want to fill out the form again because you may have typed your email address in wrong. That seems to be the most common reason it fails. If none of that works for you, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the form. Thank you to everyone who's attended live and on the web, and we will see you all next time.